Hello everyone, this is my presentation of my proposed study. My study topic is compression-only CPR in the early treatment of cardiac arrest by trained rescuers. The research question I'll be attempting to answer through my research is, during the initial treatment of sudden cardiac arrest in out-of-hospital patients by trained rescuers, do ventilations in CPR impact patient survival? To start, I wanted to provide some background information on cardiac arrest. Almost 7,000 cardiac arrests occur in Ontario each year. Almost 500,000 deaths per year in the United States are attributed to sudden cardiac arrest, of which 47% occur outside of the hospital. A person's chance of survival is greatly affected by the use of CPR. The survival rate of out-of-hospital cardiac arrest is less than 6%, and the probability of survival declines by up to 10% with each passing minute. CPR guidelines now emphasize the importance of delivering high-quality compressions while minimizing interruption. Decreasing interruptions in compressions are likely just as important as compression rate and depth. This knowledge has prompted research into forms of CPR that minimize compression interruptions. The reason I feel my research is significant is there is an overall low survival rate from cardiac arrest. CPR is an important factor in the survival of cardiac arrest. Ventilations are a significant aspect of the current CPR being provided by trained rescuers and may be negatively affecting patient care. And finally, several studies to this point have suggested that positive pressure ventilations may not be critically important to the outcomes during the first 6 to 12 minutes of CPR in adults.
I also wanted to briefly provide some background knowledge on current CPR. The newest CPR guidelines are emphasizing the importance of delivering high-quality compressions while minimizing interruption. High-quality compressions are focused on compression rate and depth, and this has been associated with positive cardiac arrest outcomes. Any interruption in chest compression results in lower coronary perfusion pressure and presumably less myocardial blood flow during CPR. Increased frequency of positive pressure ventilations reduces survival rate. The detrimental effect of high-frequency ventilation is thought to result from both interruption in compression and the obstruction of venous return to central circulation because of high intrathoracic pressure during ventilation. CPR, consisting of only chest compressions done by bystanders before the arrival of emergency medical services, has resulted in a treatment efficacy that is similar or even superior to that associated with standard CPR. And as I said before, positive pressure ventilation may not be critically important to the outcome during the first 6 to 12 minutes of CPR in adults. During a literature search in preparation for developing my research, I came across a number of studies that involve compression-only CPR. It's primarily being used in treatment prior to the arrival of paramedics and the fire department. So the first study that I'll include or talk about here involves emergency medical dispatchers providing CPR instructions to the witnesses of cardiac arrest. And this study found that CPR based on compression only was having treatment efficiencies that were consistent with the same or even better than standard CPR. However, this study really wasn't geared to providing or showing any difference in the survival and the true outcome of patients, which is ultimately what we're looking for. The second was a prospective observational cohort study that involved adults in out-of-hospital cardiac arrests, and researchers did compare survival in those who received conventional bystander CPR with survival in those who received compression-only CPR. And this study was able to associate an increased survival rate with compression-only CPR, and they provided numbers that seemed fairly significant, an increase from 4 to 10% using compression-only CPR. And the third study, and really the only one in which I could find where trained rescuers were utilizing compression-only CPR, was out of Arizona uh, and in rural Wisconsin. And this found that minimally interrupting CPR was utilized and emphasized minimizing the interruption in chest compressions. And this was done by sets of 200 compressions and stopping only to analyze the rhythm and defibrillate if necessary. And this study seemed to have found an improvement in neurologic outcome. The real gap in knowledge in the use of compression-only CPR during the treatment of cardiac arrest is the lack of a randomized study including trained rescuers providing compression-only CPR in the treatment of cardiac arrest. Uh, there also needs to be some specific research addressing how survival is impacted by CPR. There is a lot of information out there that talks about the treatment efficacy that is similar or even superior to, but this really is not addressing survival. And bystander CPR, which is being proven to dramatically affect survival rates, specifically when compression-only CPR is being used, is really only one part of the treatment process and is not allowing us to definitively define what type of CPR will be best for the trained rescuers when they do arrive. The objectives of my research are fairly straightforward. I'm aiming to determine the effectiveness of compression-only CPR in the early treatment of cardiac arrest by trained rescuers, determine how compression-only CPR impacts survival from cardiac arrest, and compare patient outcomes with compression-only CPR versus traditional CPR. My study will be a single blinded cluster randomized crossover control trial with two intervention groups. The first group, Group A, will consist of CPR with chest compressions only, and Group B will consist of standard CPR, specifically consisting of compressions and ventilations. I'm going to define my clusters by geographic region or EMS service. The standard CPR intervention group will be provided basic airway management, which may include oral or nasal airway, suctioning during the first 3 cycles of CPR or 6 minutes. The compression-only intervention group will not be provided any airway management or ventilations for the first 3 cycles or 6 minutes unless the rescuers encounter significant vomit, blood, or other secretions that are requiring immediate suctioning. Neither intervention group will be receiving any advanced airway management, which may include intubation or some other form of advanced airway until after the fourth analysis or defibrillation, if indicated. And standard CPR will be utilized after that point for the remainder of the resuscitation in both groups. My selection criteria will be adults who are treated by paramedics or fire department personnel for non-traumatic out-of-hospital cardiac arrest. Anyone with non-traumatic cardiac arrest will be included. The exclusion criteria consists of any individual with a written DNR or advanced directives, anyone who has suffered any form of trauma, including blunt, burn, penetrating, or some form of exsanguination, will be excluded, or any patients with obvious primary asphyxia or respiratory cause as the cause of cardiac arrest. In addition, prisoners, pregnant females, and patients under 12 years old are going to be excluded. My strategy in recruitment will be, as I said before, to utilize EMS services and their associated fire departments who agree to randomly cluster patients into compression only or standard CPR groups. The trial will be done at numerous locations across the United States and Canada. I'm hoping to involve upwards of 20,000 fire and emergency medical service personnel who will provide a population of almost 15 million people from urban, suburban, and rural regions. And my hope is that over 20,000 patients can be expected to be enrolled from both the United States and Canada. And I'm expecting this study to last approximately 3 years. My measurement methods will consist of my predictor variable, which is compression only CPR in the place of standard CPR during the resuscitation. The outcome I'm hoping for is a change in survival rate between patients receiving CPR with compression only versus standard compression, and survival will be defined as survival to discharge from hospital. My hypotheses, my null hypothesis is patients who are treated using compression-only CPR will show a similar rate of survival compared to patients treated with standard CPR. My alternative hypothesis is patients who are treated using compression-only CPR will have improved rate of survival compared with patients treated with standard CPR. I will be using a bivariate analysis plan to complete my study, and because survival can be categorized as a nominal variable, I'll be using a chi-squared test to complete my data analysis. A couple of the limitations I've identified in my research plan are my study is going to rely on trained rescuers from a variety of different service providers that may have different scopes of practice and treatment procedures. This lack of consistent patient care outside of CPR um, may decrease any validity in the results of my study. Further to this, no attention is going to be paid to whether there are benefits from compression-only CPR in cardiac arrest associated with non-cardiac causes. And finally, my study is not going to incorporate bystander performed compression-only CPR prior to the treatment from the trained rescuers. Bystander CPR is proven to positively affect survival and may affect response to treatment from trained rescuers taking over. Uh, I feel that these factors are something that is to be studied after. My hope is to first individually define how compression only CPR is affecting patient survival. I've provided here all the references I used in creating this presentation. Thank you.